Yes, I guess we will now begin to discuss the nature of glaucoma. Let's see here. So I was assigned a rather long title of Natural History and Pathological Processes of the Glaucoma. But in the short, it's what is glaucoma? Our word for glaucoma comes from the Greek word glaucos, which means simply a hazy light blue or sea green hue, something that nowadays would be attributed to a cataract or corneal edema, or actually would be applied to a person from Scandinavia who had blue eyes genetically. The Greek word glaukos evolved to glaucoma, and glaucoma appeared in the English dictionary in about the mid 17th century. And at that time, it was just either a cloudiness or a haziness inside the pupil, or maybe the cornea, or maybe just the pupil. And we would now recognize these as corneal edema and cataract. Couching was a process by which you would insert a needle into the eye through the pars plana and engage the lens and rotate it down to the inferior equator and get it out of the way. The best surgeons were the ones who could do it the quickest in less than a second because it was very painful. Glaucoma was then a haziness that was not corrected by couching, or vision was not restored. Amaurosis was the term used for any disease that darkened the vision, and there was no apparent cause on the exterior of the eye with available light sources, which might be a candle or an oil lamp, could be light coming in through the window, or most likely light from a fire in the fireplace or the hearth, which illuminated all of the room during day and evening. So that you could see what was going on. Amaurosis thus included anything that was in the inside of the eye, like retinal detachment, macular degeneration, and so on, and including chronic glaucoma. Now, it was noticed that those that had chronic glaucoma seemed to have a firmness or maybe a rock-hard eye and experience pain and redness. So the characteristics included that plus the haze that was called glaucos. And it was thought that the problem could be caused by bad humors coming from the iris. And so if you removed the iris by an iridectomy, it might benefit the situation. So an iridectomy was often done, the larger the better. Now, after the iridectomy, some eyes were softer, most were, and they could have, you could have opened a closed angle in them with our modern understanding of this disease, or there could be some drainage from an unintended fistula, and some of them improve vision, which implies that some didn't. How can you see into the eye to see what's going on? Murray immersed a cat in water. Well, okay. Purkinje noticed the fundus of some animals accidentally on occasion. In 1847, however, was when a mathematician figured out a way that you could be able to see inside the fundus and recognize what the problem was. But it was 3 years later before Helmholtz, quite independently, not knowing of Babbage's work, developed the ophthalmoscope. Now, the problem is that the pupils are black. What does that mean? It means that the illumination in the room was illuminating some part of the retina other than the part of the retina that you see by looking directly into the eye. That part of the eye was not illuminated and was in the shadow of the observer, so to speak, and therefore you couldn't see anything but black in the pupil. The problem was solved by Helmholtz by using a candle and having a mirror that shined the light into the eye through a lens, and it's an indirect ophthalmoscopy, and there was a hole in the mirror so that you could see it's in the same axis as the beam of light that was illuminating the inside of the eye. There's a diagram of the candle going to the mirror, into the eye, and then being visualized by the person through a hole in the mirror. Now, let me go off on a tangent for a moment. The ophthalmoscope was actually the most important event of all time for understanding eye disease. Before this, you just had to call everything amaurosis if you didn't see any cause. Helmholtz recognized the importance of his invention in that you could now see inside the eye and see what was going on in patients that you couldn't understand before, why they didn't see. He did, however, refuse to patent his invention, despite the urging of his friends and colleagues, because he thought that it was so important that everybody should know how to do it and they could build their own ophthalmoscope and sell them. He was satisfied to make ophthalmoscopes and sell them to the local people, but he didn't want to patent it and prevent other people from doing so as well. Over the next 50 years, there were at least 350 modifications to the ophthalmoscope described, and they were shown at a meeting held celebrating the 50th year after the invention. One of the additions was to illuminate things by electricity, which had come along meanwhile, about 1900 or so. And it was powered by a wet cell battery, like the battery in a car, and then wires that went up, and you could see that it, here's the wire coming up to the ophthalmoscope. It's now being used to illuminate things, and this one was apparently a direct ophthalmoscope. The idea of putting a dry cell in the handle of the ophthalmoscope was brought up by Crompton, and it was commercialized immediately thereafter by Welsh and Allen, which became a well-known company for making instruments, including the first handheld direct illuminating ophthalmoscope. Now, the impact was that there was a demolition of the puzzle of what on earth was going on with amaurosis. There were guesses and speculations, theories and discussions, and of course it was discovered there were many different causes of amaurosis. Okay, returning back to the subject about the nature of glaucoma, with the ophthalmoscope, it seemed that there was no particular change in the fundus. The retina looked just fine. That view was replaced by the belief that there was swelling of the disc that some people thought they saw, but they actually had it backwards. Von Graefe demonstrated that it was actually an excavation of the disc that was seen in glaucoma and not a swelling. And he also observed retinal pulsation. So now for glaucoma, we had vision loss, high pressure, very high in some cases, and excavation of the disc. And these characterized what was known as glaucoma. How did they fit together? What's the central feature? Well, the pressure. The pressure is what caught everybody's attention. They were hard as a rock. And in the 1880s, by the mid-1880s, palpation with different degrees of firmness of the eye and 9 degrees were described. And so evidently there was varying pressure between eyes, some of which were high. And it was determined that there should be some way developed to measure the pressure. And that was finally done at about 1900 with instruments. Schiot's was a popular one, not the first, but the popular one invented in 1905. It required calibration to eyes with known pressure, and that was done in 1948. Thought to be a bit inaccurate, so it was done again in 1955. Turned out the 1948 one was probably better anyway. But applanation tonometry, meanwhile, came along, and that became the standard. All of them just estimate the pressure. None of them really measure the pressure. Glaucoma is then defined by having a high pressure, and then by what caused it. There were 3 types of glaucoma described where the cause was unknown. In one of them, the angle was open, but there was nothing apparently wrong with the eye, and so the pressure was primary. It was idiopathic. It was the thing that just arose on its own, and there was nothing earlier in the pathogenic pathway that was understood or known. There were some eyes that had angle closure, and that could be recognized as being the cause for impeding outflow of aqueous humor and hence having a high pressure. And then the other one that didn't seem to have a cause other than some congenital anomaly, presumably. Anyway, if the child was born with a high pressure, that was congenital glaucoma, though you couldn't determine why they had the high pressure. Then there were many secondary glaucomas, things where you knew what caused the pressure, things like pigmentary dispersion, pseudoexfoliation, trauma, and angle recession, eye syndrome, and so on and so forth. And there were several dozen of them, and they were tabulated and described in the textbook that was used after 1950 or so, and written by Becker and Schaefer. And they cataloged and characterized and gave the treatments that were available for each of these different kinds of secondary glaucomas. Now, the pressure is the source of the problem, it seemed, because if you had secondary glaucomas that caused an elevated pressure that hadn't been present before, and that caused cupping and vision loss. And you could raise intraocular pressure in animals, and that resulted in cupping. And so it seemed that the pressure was the central issue. So when I was young, it was all about the intraocular pressure. The type of glaucoma was defined by what caused the pressure, and the treatment goal was to bring the pressure into the normal range. It was simple as that. So to diagram that, this is the frequency distribution of the intraocular pressure in the population, and anything that was higher than the mean plus 2 standard deviations, which was 21 millimeters of mercury, anything above that was harmful. And either you already had some vision loss or it was inevitable that it would happen. On the other hand, anything below 21 was perfectly normal and seemingly safe, so that if you had that, you had no worries. Well, things have changed. And now we view glaucoma this way, that there's a skewed frequency of elevated pressure, or pressure, let's say, and elevated pressure would be above 21, all of these people here. Now, visual field loss was something different. Here is the frequency distribution in brown for visual field loss. And in the normal range, there weren't very many people. The ones below 15 aren't really real because that's just the width of the pen of the person who drew the diagram. But you started to see some people before you reached 21 that had glaucoma as field loss. That was sort of a puzzle if pressure was supposed to be the cause. And even with a very high pressure, the mean pressure of people with glaucoma was about 23, not really very far out of the majority normal. And even going up to pressure in the 30s or above, there were some people who didn't have any loss of vision, only some fraction of the people with elevated pressure. And let's take somebody at 24. There were more people that didn't have field loss than there were people that did have field loss. I wonder what that was all about. Well, Armley actually measured, according to age, what the incident or the prevalence was of visual field loss from glaucoma, and there it was. And here is the prevalence of pressures above 20 millimeters of mercury, that is 21 or higher. And they greatly outnumbered the number of people who had abnormal intraocular pressure. And that was a puzzle. This was confirmed in other studies here. For instance, is the black jagged lines is a distribution of people with different pressures at 1 millimeter mercury intervals. The dotted line is a Gaussian curve just superimposed and shows that it was more or less a Gaussian curve, except that the population had a skewed pressure in the upper ranges. Now, down here in the shaded bars are the people who had vision loss. Some of them actually were in what you'd consider to be the normal range. Others were in the range of pressure that would be considered elevated, above 21, and so forth. But there were a few outliers really in the high pressure range that had no visual field loss, and hence they're not shaded. And so that was true of all these people between the Gaussian curve and here as well. They had no visual loss despite the fact that their pressure was high. So how do we explain this deviation of reality from what would be expected? Well, ocular hypertension. Maybe it just takes time, but it was felt cupping and visual field loss was inevitable if your pressure was in the elevated pressure range. And therefore, that is because high pressure is harmful and you must treat them. Another rationalization on the other end is that people who had normal pressure must have had some pressure in the past, or they had a variation in pressure, and while they were sleeping or some time of the day or after they drank a lot of water or coffee, the pressure went up, but at other times it was in the normal range, but at least it had some time in the, or maybe they used corticosteroid eye drops when they used contact lenses. And during that time, the pressure was high, but in their older age, they stopped wearing contact lenses, stopped taking the steroids, this pressure came back to the normal range. And now, as you see them, they have cupping of the disc that is typical of glaucoma and visual loss, but the pressure is normal. But it wasn't normal before. That was the rationalization. They need to be treated, or they didn't need to be treated, however, even though they had cupping and field loss, because now they have a normal pressure, and that's not harmful. You see, glaucoma is all about being high, stupid. So there. Well, since over the subsequent 60 years, there's been considerable change. Armley began to question whether high intraocular pressure indeed defines glaucoma. He began to explore the natural history of what we now call ocular hypertension. Bo Bengtsson and other people in Sweden actually thought that the intraocular pressure and the cupping and field loss were two separate things. Some people, and they get older, they got cupping and field loss. And some people had higher pressure in their eyes than the younger people. But neither one caused the other. The pressure didn't cause the cupping and field loss. And because of that, there was no need necessarily to treat the intraocular pressure and make it normal because it was not doing anything. Just a few years later, in the 1980s, Eddie, who was a pioneer in evidence-based medicine, pointed out there were many conditions in medicine for which there was not much evidence of what was causing it, and not much evidence that whatever treatment was being used by tradition and as taught by the professors whom you believed without asking for evidence. He challenged that and said there wasn't any actual evidence in the literature, and he chose as one of his examples ocular hypertension. Said there's no evidence for that being treated, no evidence that glaucoma needed to be treated or that any benefit arose. Oh, and everyone was so disturbed by that concept. Of course, the intraocular pressure is harmful. We all know that. And that's what's causing the problem, and you got to treat it. It would be unethical not to treat it. And Eddie said, where is your evidence? And annoyed everybody. It turns out, however, maybe he was right. There wasn't any actual evidence that doing anything about the pressure brought any benefit. And now we know what we know. Now, how should we think about the intraocular pressure now? We use it for screening in the community, and that turned out not to be a very productive adventure. Didn't uncover many cases, and a lot of cases went undetected, and began to realize that the two were disconnected. But we still in the office, check the intraocular pressure and say we're doing a glaucoma test, as if that would detect glaucoma. And if you remember the graphs that we had, that would only detect maybe half of the people with glaucoma, and most of the people who screened positive with an elevated pressure actually didn't have glaucoma. So it's not very effective. Of course, we take the opportunity. When the person's in the office, we do that. It is one of the risk factors that we now know to be true, that it can lead to or be a sign of an existing glaucoma. And so we continue to do that in the office. Every single visit is just part of the routine exam. Do we need to do it every visit? Oh, probably not. Probably if we're, checking the pressure once a year or something like that, once every few years, that's enough. But we still check it every single visit on that comes in for dry eyes or anything else. Nowadays, however, we don't really believe that the pressure is the real key. With reference to management, we understand that glaucoma is identified by other things besides the pressure. And once we have done that, we look at what the pressure is and we set a target pressure, something that Paul Pomberg has strongly advocated, in order to get it to a safe level. So instead of separating normal and abnormal, we now want to separate safe and unsafe. And the evidence for being unsafe is that you already have some cupping and field loss. And if the pressure is 23, let's say, and you lower it to 17, maybe that's quite enough. You got it into a safe range for that particular person's eye. If somebody has a pressure of 35, maybe they're, and the cupping isn't really total or anything, maybe just getting it down into the low 20s somewhere, 23 or 24, maybe that's good enough. And so we might undertake management that brings it to a safe level in that eye. And until something comes along to change our minds, we might consider 23 to be good enough. We don't have to go to a dangerous level of treatment or one with a lot of side effects unnecessarily. But we're not simply trying to get it to the normal level. The other way that we use intraocular pressure is to look for effectiveness of treatment. So before and after you start a treatment. And once you get what seems to be a substantial lowering of pressure, and you have reached your target, you measure the pressure on every visit. Now it seems worthwhile. They actually have a disease related to pressure, and it's worthwhile measuring it every time to see whether or not you're at your target, but not to see whether it's a normal pressure. So intraocular pressure is a risk factor: age, family history, vascular dysregulation, cardiovascular state. We're going to get into all that. They're all risk factors. Then the disc tells you whether or not there seems to be something wrong, and in any suspicion, you get a visual field test. That's how we detect glaucoma currently in the office. So what are the mechanisms behind this? First of all, the mechanism for the elevated intraocular pressure, and secondly, the mechanism for damage to the disc. With regard to the pressure, the resistance seems to be in the outer trabecular meshwork and was shown, in the 1960s, and studies around that time by people who worked in the laboratory and were able to kind of shave off parts of the trabecular meshwork and determine that increased the outflow of aqueous humor. To a lesser degree, there's some resistance in Schlemm's canal and the collector channels, and then there's the episcleral venous pressure. And all of this leads to Goldmann's formula, which you should know, which relates the intraocular pressure to the resistance and the venous pressure, as well as the rate of flow of aqueous humor. Those are the three things that determine pressure. Sonography was used to measure the resistance. It was one way to be able to do it in a living person. And when it was used clinically, however, it was found not to be more informative than measuring the pressure itself. And so while it was used clinically for 5, maybe 10 years, rather routinely, it was discarded after that. There are laboratory studies or biochemical studies, let's say, about the trabecular meshwork and to understand what's going on there in order to have the resistance. And I don't know too much about those things. There is one medication which is involved generally in cell contraction, rho kinase inhibitor. Rho kinase is responsible for contraction. The inhibitor inhibits that, and it does lower the intraocular pressure. I don't know whether more often or much lower than with other medications, but it's something that's there, and I don't know much more about that, and so we'll move on to something that I do know more about, and that is the optic nerve end of the equation here. The intraocular pressure will induce a blockage of axonal transport. It's the first physiologic process that was discovered to be upset by raising the intraocular pressure. So what are we seeing here? This is an eye where a radioactive amino acid, probably leucine, for example, was injected into the vitreous. It was taken up by the Golgi apparatus in the retinal ganglion cells. And the protein that was created there was carried along the axons through the optic disc and all the way to the lateral geniculate body. What we see here is that the radioactive material was being carried along but got hung up in the region of the lamina cribrosa, or at least where it goes through the choroidal layer. And it doesn't get to the lateral geniculate body. The whole process takes 4 hours to get there, but here after a few hours, you can see that it doesn't get there at all because it's hung up here when the intraocular pressure is elevated. And the degree of blockage is related to the degree of elevation of intraocular pressure and everything else. Now, the problem is that blockage of axonal transport is a lethal injury to the axons and their ganglion cells, because there are also messages being carried in the opposite direction by the same active transport process that's carrying some proteins in the orthograde direction. And if the ganglion cell is not receiving messages from the receptor, it decides it's become disconnected, and it undergoes a process of apoptosis, and the ganglion cell dies. Apoptosis is a process where the nucleus creates some enzymes and things that simply dissolve the cytoplasm of the cell, and it liquefies, and it's just absorbed into the body fluids, and so on. It's the opposite of a cell dying by necrosis. In necrosis, the cells are deprived of blood flow and nutrients, and the cell just dies. It doesn't get dissolved. And so macrophages and inflammatory cells have to come in and sort of clean up the mess behind the dead cells. And that causes a retinal inflammation around the dead cells to clean it up. Very different process. This process is a self-imposed death when it's disconnected from its target organ. So now we can talk about methods by which the intraocular pressure blocks axonal transport. Been some debate about this in the past, at least. There might be some mechanical thing. The axons are kinked where they're leaving the eye through the lamina cribrosa as they go through the sclera. Or there's a pressure gradient along the axon, or some mechanical reason for the blockage. The contrary viewpoint, or an alternate viewpoint, is that there's some ischemia that's localized in the region of the deep optic nerve head because the transport is oxidation dependent, dependent on ATP, oxidation process, and ATP is not formed if there's no oxygen around. And the vascular consequence of intraocular pressure is that there is no active energy in the form of ATP to conduct the transport. I happen to believe that's the main mechanism. Not everybody is fully convinced, I guess, now. But here we come back to our diagram, and this blockage, I indicated that the degree of blockage was dependent on how high the intraocular pressure is, but it turns out that if you give a vasoconstrictor of angiotensin, it makes it worse. Now, angiotensin can't enter nervous tissue, the brain or anything else, because of the blood-brain barrier. So it doesn't enter into the retina or anywhere along the optic nerve or inside the brain, except where there's a defect in the blood-brain barrier. And that is at the choroid. The choroid has no, it doesn't have a blood-brain barrier, blood tissue barrier, and the angiotensin can seep out into the optic nerve head and cause vasoconstriction locally in this particular region. And so even though angiotensin raises the blood pressure at the same time, it should make it easier for blood to flow through the area, there is a worsening of this blockage by angiotensin. Other evidence that blood flow is involved is that there's a relationship to the diastolic blood pressure clinically. And there are hemodynamic crises that can cause an acute kind of cupping. And nocturnal dips in blood pressure occur in some people, and those people sometimes have glaucoma. And so other vascular events seem to affect it. There are lots of studies about the relation of what's called ocular perfusion pressure. That would be the blood pressure minus the venous pressure. That's what pushes blood through the capillary bed. It's intraocular pressure is substituted here because one of the things that intraocular pressure does is to raise the venous pressure. And it's above that the venous pressure would be in the orbit. And so the circuit that's in the optic nerve head, or in the eye in general, in the retina, is the blood pressure minus the venous pressure of the eye, which has to be at least as high as the intraocular pressure. Another evidence for blood flow involvement is that migraine and vasospasm and vascular dysregulation and other vascular problems are related, and we'll see some things about that. There is an uncertain relationship with arteriosclerosis. Now, that's in the larger vessels of the eye. And these two, the microcirculation, which is affected by vascular dysregulation, and macrocirculation, the arteries, are affected by arteriosclerosis, atherosclerosis, and so on. And so all of this suggests that that the vascular system is somehow involved in this problem. Now, a separate topic is that cells undergoing apoptosis can be made to be fluorescent. And these fluorescent cells can be seen in retinal images and be counted. And the number of fluorescent cells reflects the rate of progression and guides there. In other words, the more cells there are that are undergoing apoptosis, the more progression that's occurring at the moment. A clinical method to do this is under development. It might be 10 years or so before you see it, but it's coming, and it's based on the fact that there is apoptosis caused by axonal transport, seemingly. Now, the other aspect of this that's of interest is that the blood flow in the capillary bed is autoregulated in CNS tissues, central nervous system, CNS. And that includes the retina and the optic nerve and everywhere else. So a study was done on the optic nerve head of 10 normal subjects of the blood flow in the capillaries of the optic disc. Wasn't an easy study to do, so there were only 10 subjects. In 8 subjects in the left here, the blood flow remained the same in the capillary bed until you got up to about 50 millimeters of mercury, which happens to be near the diastolic blood pressure of the patient, or not patient as a normal subject, And this black bar represents the blood pressure. And then when you get higher, why then finally the blood flow declines. When you release it, as in the open circles, the blood flow is restored as the intraocular pressure is brought back down in steps. There was a little bit of an overshoot because of hyperemia right there, and finally it comes back to the baseline. In two subjects, it was quite different. The blood flow diminished as you raised the intraocular pressure. And then when you released it, the blood flow came back. So these people didn't have any regulation of the flow. The flow was diminished. Now, one of the interesting things about this, that in the ocular hypertension treatment study, the number of people who were found to have ocular hypertension and were followed without treatment, who nothing happened to, was about 80%. Only about 20% of the people over a period of several years developed glaucoma. That's interesting. It means that some people may have elevated intraocular pressure, nothing's happening to their blood flow, and in the long term, nothing happens to them. Might bring up the treatment question of whether they need treatment. So the hypothetical elements of ischemia is that there may be a deficiency of metabolic autoregulation in some people, and therefore ischemic damage. In addition to there being intermittently, at least perhaps, a change in the blood flow, there may be, when there's a restoration of blood flow, there is a reperfusion injury. That's a well-known physiologic phenomenon, that if you make an area ischemic, it's okay for it to be ischemic for a certain length of time, and then it can be released. It's why you can have your blood pressure taken and cut off all the blood flow to the rest of your arm, and then why nothing happens in particular, because there's reperfusion promptly. But if the reperfusion is a little bit prolonged, why there can be an injury caused by reactive radical ions, and there can be an injury to some of the tissue because of that. And that could be occurring if there's intraocular pressure elevation that exceeds the ability to auto-regulate, and it lasts for a couple, 3 hours, and then you release it. The axons might be saved, but there might be some injury. Hypothetical. There is a variation in ocular hypertension sensitivity. And for example, you have normal tension glaucoma, but there normal tension glaucoma study that we'll get to show that if you lower the intraocular pressure, it helps some of the people anyway. And so although the pressure participates, there's a lot of individual variation about how harmful it is. That's the message from here. Blood flow should be lowered when there's an arteriovenous pressure difference that's reduced, but autoregulation maintains the blood flow, at least in some people and at least some of the time. What are the clinical signs of dysregulation? We can recognize people who have a problem with the regulation. Remember, there were the two normal subjects that didn't regulate very well. They tend to be nervous people that have cold hands, cold feet. They wear socks when they're sleeping. Their hands and feet get cold when they're nervous, like when they have to give a talk. Oftentimes they had a low blood pressure when they were young, so there was only 100/60 instead of the normal 120/80. They oftentimes don't have a real sense of thirst. Yeah, they drink water because they need to wash the food down and they know they should drink water, but they don't have a sensation of thirst when they don't have water for a while, like people have a sensation of hunger. Other people do have a sensation of thirst when they have gone a while without drinking something. Migraine headaches. Takes them a long time to fall asleep. Instead of 5 or 10 minutes, it might be half an hour or an hour. Tinnitus, I haven't actually seen that, but it's described. Now, There has been discovered some evidence for two different kinds of glaucomatous damage when people consider the amount of damage and the level of intraocular pressure that are brought into clusters. There's a very interesting paper on this that we don't have time to go into, but basically what it shows is that some people have damage, the severity of the damage in their eye is unrelated to the level of their intraocular pressure. Whereas people who have the dysregulation that we just described in the microcirculation, as opposed to the major arteries, their damage is related to the intraocular pressure level. Well, do you have any questions?